Dr. Katie Dabrowski. We've been chatting for a while. Finally, great to have you on. I was just listening to your episode where you appeared on the Coach 'em Up podcast. I'm flying down to see Tim soon to appear, so excited, but got a lot of notes. But for those of my audience who are not overly familiar with you, they should be. Doctor of Physical Therapy, certified strength conditioning coach. You've got a Bachelor of Science in Behavioral Psychology and Neuroscience, which is really cool, especially in our world. Co-founder of
Yes.
Oval Athletics in Miami. And if I have this correctly, you are an adjunct professor at the Department of Psychology and Neuroscience at NSU. Pretty impressive
You did
resume.
your research. Yes. I wear a few hats. I'm very tired and caffeinated. So yeah, those are the main things that I do.
Well, I wasn't going to go into the rowing time as a Div 2 athlete and how I don't think you ever actually slept in college, but
Correct. Yeah. I think my baseline was so low that anything feels better now. So a great reason to do the sport of rowing. It just prepares you later in life for anything else.
this is totally off topic, but relevant to that point. I have a theory. I've trained doctors, and I do not believe people physiologically adapt to low sleep, but I think that they psychologically adapt to it where they think they're functioning better.
1000%. I also think there's a lot of like rationalization of just being like, yeah, I can handle it. It's fine. Yeah, I completely agree with you. There's genetic variability of people who maybe their cycles are shifted a bit and they need more or less, but I don't think you can physiologically adapt. I think you psychologically blind yourself and think you're okay when you're probably not. So big fan of sleep nowadays, but back then it was tough.
This episode is brought to you by Just Bite Me Meals. I work long days and I won't compromise my client experience or sacrifice my workout, sleep, or nutrition. So I needed a quality and reliable meal prep service so I could save time on cooking and shopping and have more time for the stuff that matters. Net out the cost of groceries and the service isn't as much as you might think, and regular impulsive food delivery apps, eating out, that costs way more anyway. I get more meal variety and less dishes to clean, and I've been referring clients to Just Bite Me Meals for a long time, and I recently started ordering myself. Food is great. The beef brisket tacos are my favorite so far, and there's a lot of menu choice. Your calories and macros are listed. The portions are great. You can order custom meals. They deliver to your door, or you can pick up from their storefront. And I'm sorry to listeners outside of Alberta, but Just Bite Me Meals is currently just in Edmonton, Calgary, Grand Prairie, and Fort McMurray. Ordering from Just Bite Me Meals made my life easier instantly. And you can get 10% off on all your orders using my code, Andrew Coates Fitness, all caps, on their website. That's Andrew Coates Fitness, all capitals, or go to the link and the code in the show notes.
You know what? Because of your background, this wasn't something I planned, but it bubbles to the surface. I think a lot of people deal with, I have hard sleep boundaries around sleep time. Like 8 hours sleep opportunity, that's pretty much non-negotiable for me, except for like rare shit. If I have an early flight, no matter how early I shift, it still screws up my sleep. You know what?
Totally.
I want to comment on that because you've got the average enthusiast listener, some coaches in here. And let's say that's the person who is struggling with giving themselves a sleep boundary opportunity. And they say, oh, no, I can function. Are they?
Yeah, I mean, I think it's one of those things where you can kind of get used to a certain level of functioning for a long time and not realize what you're missing out on. I speak about that a lot with clients too, with food and caloric intake, especially on like the under eating side of things. Like you can get by for a while, maybe if your body's kind of used to being under fueled and then think you're performing really well. And then all of a sudden actually feel properly and you train and you're like, oh, this is what it feels like. So I feel like it's very similar with people who are chronically more sleep deprived. You kind of just think it's your normal functioning and your baseline. And because you can get through the day instead of like attacking the day, being really well rested, I have a feeling people just get kind of used to that. But unless you're a pretty rare person on the genetic spectrum of somebody who's like circadian clock has shifted so much so that they really actually biologically maybe have a lower sleep need than other people. It's very rare where it's not your average person walking around. So I would just venture to say that most people need a lot more than they think.
That's probably wise. All right, so let's go on to the stuff I had planned. Can someone return to life in sport? How can someone return to life in sport when restricted by a fear of the pain that they're going to encounter and as a result of a previous injury?
Oh, hitting heavy with the very first question. I like it. Yeah, I would argue this is probably a bigger factor in rehab than even the physical
Mm,
rehabilitation side of things. And I also argue the way that you do it goes perfectly hand in hand. A lot of the work that I do, and as a reminder, like I'm not a psychologist. I don't deal with these things from that perspective, just using psychological principles. And then luckily having a network of people to refer out when it absolutely is out of my scope. But I think as coaches and rehab providers, we have to be well versed in human psychology and
mm.
behavior, and be able to navigate these scenarios when they're appropriate within our scopes of practice. So that's the disclaimer there. But yeah, a big reason I'm such a proponent for really hammering the thought process of helping people find an entry point to the thing that they're trying to get back to. So that day one entry point, what is the maximal tolerable dose or position or modification or way of doing a movement that looks most similar to the thing that they're most fearful of and the thing that they want to get back to? How do I find that day one? That's not just to make their tissues tolerate it better. I'm really thinking of it almost even more so, especially in the very beginning, a way for that person's brain to start to like tolerate this movement better. The example I often give, because I think it's just very clear and a lot of people encounter it, and there's a lot of misinformation of the, in quotation, dangers of this movement, but it's deadlifting. So many people come in with low back pain and their fear is around specifically deadlifting. And my number one goal, once I've ruled out neurological red flags and things that would be, again, out of my scope or not appropriate to start with somebody with this day one, I'm finding a way for somebody to get into a hinge position immediately when I meet them day one, because it's so important to start to kind of undo the fear around that movement. And if I say that it's important, but we do really low level stuff day one, then I'm kind of just perpetuating this idea of like, but you're still not ready. So that's a really, really big thing. It's that gradual reintroduction to movement, thinking of it not just from a physiological lens, but from a psychological lens. So I would say that's really the goal. Like, how do you find that entry point day one to get people to start to subconsciously decrease their fear? I'm not telling them to not be afraid because that's not really helpful either, but I'm showing them with a positive experience with the thing they were maybe a little bit fearful of that it's okay.
Almost sounds like exposure therapy for phobias, like someone's just afraid of
Yeah.
snakes or spiders.
Yeah, it's very similar to that. And it's something that I think when we get into this space of talking about entry points, a lot of people are really just speaking to it from the physiology standpoint of progressively introducing tissues that haven't been in that position, especially maybe with load or something with like higher intensity or higher stakes to the person in a very long time. And why that's so important, right? I mean, most people, when they have pain or injury, unless there was a really traumatic event, it's often because they maybe asked their body to do something and their tissues to do something they weren't really used to being exposed to yet, or they hadn't been exposed to progressively, or they had a while ago and you kind of picked up where you thought you left off. So physiologically, that's really that sweet spot for that entry point. But then that the second lens, of course, is the psychology side of it too.
This episode is brought to you by Macros First. I've always struggled with nutrition tracking apps, even the slightest hassle or friction, and it breaks my habit. That changed with Macros First. When I tried it, I told my friend, the founder, Jacob, quote, this is, well, let's just call it a certain other app on steroids. It's the easiest app to use, and it has a free barcode scanner, which if you use tracking apps, you know this is a really big deal. I recommend Macros First to all my clients and friends, and even had them sponsor my 2024 conference. Here's an example feature that I love. The verified food database. Remember using other apps and searching for a food only to find 10 to 50 similar options with different macros, not knowing which one to pick. This kind of friction is the shit that made me quit tracking altogether. Macros First, every single food item in the database, over 3 million of them, is human verified. No junk entries, so you can trust the numbers. Plus, that free barcode scanner makes logging faster. And if the barcode doesn't turn anything up, just point your camera at the nutrition label and Macros First will extract all the nutrition info instantly. All this just makes tracking easier. And while Macros First's premium version is incredible for any user, the basic version, which is nowhere near basic, is free to use. So you can go to either the Apple Store or Google Play to download.
Can you take us further into developing the psychological resilience, especially like in the context of this conversation, is going to be around injuries.
Absolutely. Yeah. I think some of the biggest things that I try to focus on with people, thinking of training around an injury is really important too. And why that's so important for psychological resilience. Because I kind of approach injury with two prongs that I care the most about. One is that entry point, and then also like how can we find basically the list of things that you can do without issues. And I think that's also again, you can consider that from two lenses. The physiological lens, like I want you to get a good training stimulus. I don't want you to get detrained during this time. I don't want to have to build you back up from zero again. I want your tissues to continue to get exposed to things. I want the systemic effects hormonally and chemically that happens when we train to go everywhere and help everything, even if we're not directly loading the area that's bothering you. So, of course, that's the physiological side that I care about, but also from a psychological resilience side, to kind of remind people like, if you have an injury, and not to downplay it and not to say that it doesn't suck, but there's probably still a lot more that you can do than you think. The amount of it in a training perspective, the amount of people who maybe come to see me with like a knee injury and they've stopped training entirely. And like, well, we have another like really great leg that we can do stuff with, and we have upper body goals that we can hit. And I think that's very important for the psychological resilience side of injury too. Again, kind of indirectly, just I'm creating an experience for you and not having to tell you that this is going to help you. You're going to start to see it because it's happening itself. I would say that's a huge component of it. Also, like it sounds cheesy, and I spoke about this on Coach 'em Up as well, of like creating that positive experience with movement and that positive environment for people. But I think that's huge as well. Of turning an injury into an opportunity, turning an injury into a way to focus on other maybe PRs or goals that you wouldn't have normally had. And I think that in itself is how we practice psychological resiliency, taking like a shitty situation and making it less shitty and making it an opportunity instead. I just did an intake yesterday with somebody who is dealing with a pretty rough knee injury and like a hip labral tear. And she's really, really frustrated. She's a former college athlete, extremely active, and she's been extremely depressed, of which, of course, we've all dealt with when we've been in pain. And I kind of shifted the conversation halfway through and said, what are some upper body goals that you've kind of always wanted to do that you haven't maybe tapped into? And we made a list of upper body goals. And it's not that we're ignoring the issue, but we're helping the whole human feel a little bit more like herself again when she feels like she's not.
This got me thinking. I have a feeling, this is just a theory, there's a sweet spot across the spectrum of people and why they do this. The really body enthusiast who enjoys it, does it for their mental health, they probably find this easier. The athlete whose identity and function is within their athleticism, probably really, really hard to manage. Then you get the person who struggles to get consistent and active, and then an injury becomes a very socially acceptable reason, justification not to go do the thing that they kind of dread, they don't like. So I have a funny feeling those either sides, this can be a big issue with. Everything you just described, for anybody listening, I have a resource. It's an article on my website, but it's really deep. And it's primarily based on the principle of cross education, training with an injured limb, the innervation that you get for the injured limb. It helps spare muscle thickness loss, strength loss. It's wonderful. But
100%,
I go into the whole thing. It's like when it comes to my clientele, which is overwhelmingly Gen Pop, I have some young athletes, lots of older adults. I want to keep the habit. I want to keep the metabolic health benefits, which you allude to, the mental health benefits. And I think because more people are coming for those, I have a feeling it's probably easier. Certainly in my experience, when I've dealt with injuries, my clients are great working around it because they're in there for other reasons.
Yeah, absolutely. No, you bring up such a good point with, like this is difficult with different populations for sure. I'm similar to you. I would say I work with more of a Gen Pop population as well. And where a lot of what we work on is often people will come in with a pain or injury, but we kind of use it as a window to open the door to like long-term health is really kind of what I'm trying to get after with most people. So it also depends on where they are in their process with me too, right? Like what's their buy-in level already? Are they somebody who just started seeing me, or are they somebody who has seen me for a while and they get kind of a flare, but they're already bought in? So that's a big challenge as well. How do we from the beginning set the expectation that I'm not only here to magically fix your pain. Like I'm not a guru. I can't 100% prevent injury. I can't prevent a flare up from happening. I can't stop these negative things from happening, but we can, train in a way where your body is as resilient as it can be and your mind is as resilient as it can be. So if we set that expectation from the beginning, I think that's a very important thing too. When you're meeting with somebody for the first time, like talking about that stuff, talking about the reality of the ebbs and flows and the ups and downs, and what your journey will be together, I think is huge. So people know from the beginning of kind of where they're getting to. And then, yeah, I mean, in general, like it's not a perfect way. It doesn't always work, of course. I wish that every single client bought in perfectly the way that we wanted. But I agree with you in that it's probably less about explaining to people the cross education and the irradiation and the neurological stimulus you're getting because we have two hemispheres and things are crossing. It's more of keeping the habit and keeping people healthy and keeping that, as you mentioned, and something I'm passionate about too, of like just a good training stimulus being a very important part of the rehab process and a very important part of the long-term health process for people.
We can come back to that because there's something big there, but let's go to the thought side. Can people
Mhm.
think their way out?
Oh, that's a great question. Yeah, I mean, that kind of that operates on the premise that I think that we never want people to think that pain is all in their head, right? Everybody is probably, especially if you're interested in the neuroscience world, you've probably like read those stories of the construction worker who stepped on a nail and didn't know it until he saw it. Like things like that, where it does show us that perception and sensation and reality and expectations and predictions all go so much and hand in hand into how we perceive a pain experience, without being so, I think, unfair to people and just saying like, yeah, it's all in your head. I think we can create a more positive thought process to help us manage pain
Mm,
better. I think we can, continue to do the things or find the ways to do the things in our social lives and in our lives in general to help like that cycle of depression that comes with disuse or that comes with not being able to do the things that you love. I think there's ways to help the process along, but I think it's a oversimplification to say like, oh, you can just think your way out of pain. I think that's something that if you tell that to a client, they're probably not going to like you very much. But I think absolutely the mindset and how you approach the situation is important. And saying this, I often realize it sounds like, oh yeah, if it was that easy, I would just think positively all the time. And every single time I get in pain too, I have the initial downward spiral as well. Like it's human nature. I also identify very deeply with being an active person. So that's an added layer to it. But I do try to think of it as an opportunity. I really do try to think of it as, you know what, actually, me going through this is just going to make me better when I'm working with my clients. Or me going through this is forcing me to work on things that maybe I neglected because I wanted to prioritize something else. So the way that we think about things, the way that we use our mindset is still a huge part of the equation.
okay. I think that's really good. All right, let's go back. Does exercise selection matter for rehab?
I love all of these. These are like heavy questions, getting right to it. You definitely you did some good research before of what I'm interested in, so thanks. Um yeah, I'm more of a okay, exercise selection. I think there's nuance to everything. I think of exercise selection as being a tool to maybe have it tied to like a goal movement, a goal target tissue, a goal stimulus, a goal contraction type, something like that. Rather than it being, well, if you're going to rehab the glutes, then you need to do this type of deadlift only. For me, when I'm considering of like why I'm selecting a certain exercise, it's tied a lot more to the stimulus I'm trying to give that person. If this person comes to me and the pattern, that's another thing. I'm a pattern person. So if their
Mm,
pattern of pain for, I'll use the glute example, for glute discomfort happens with the eccentric loading portion. So getting down into the bottom of a deadlift or a squat, then does the specific movement matter as much as me being able to challenge the eccentric position for glutes in a way that they can currently tolerate? I would argue no. For me too, what I also care the most about is can I load it appropriately or do it in a way that's going to get a good training effect and a good training stimulus? For exercise selection, like there might be this movement, this body weight movement that on an EMG study activates this fiber of your glute medius the most, but am I able to load it enough to actually get a true physiological adaptation where that tissue has now changed? Activating a muscle and feeling it burn really hard is quite different than loading it in a way that kind of comes back to that person's initial goal activity or that they struggle with. So exercise selection definitely matters, but I would venture to say it's less about the like type of movement that the person is doing and more of the stimulus you're going for, the tissue quality or the target tissue you care about. And the big thing is relating it back to like their goal activity in the first place.
And this relates to regular training anyway, because I've always
Yeah,
viewed rehab as scaled appropriate to the nature of the injury resistance training, right? As opposed to the
1000%.
the other passive stuff. I had Charlie Weingroff on recently, and we were talking about some of the
Mm,
passive modalities. And well, actually, Adam Meekins, a lot of other people on recently. Not to say that it's worthless, but it's not enough. So
yeah.
I think the fear, I can think as a coach myself, as recovering from injuries and what have you, do you have this fear that's like, okay, well, there's this correct textbook exercise that you're supposed to do for this particular issue. And because you don't feel confident about that, either as the coach or as the enthusiast dealing with the injury, then there's this anxiety almost about, well, what if I choose the wrong thing? I've come to realize with experiences that I don't believe there's this symptom means it's got to be this exercise.
Yeah. Oh, I couldn't agree more with you. I'm a big proponent of the thought process of like once red flags are ruled out, specific diagnosis doesn't really matter. It's a lot more about gradually getting somebody back to tolerate the positions that relate back to what they want to do in their lives. I care a lot less of the specific tissue, unless, again, of course, where it matters. If somebody has a gnarly tendinopathy, I'm not just going to day one make them do sissy squats to the floor
Mm.
because I know they need to get that deep knee flexion tolerance. Like there's definitely nuance to this, but as a very sweeping generalization, which I think applies a lot of the time, or at least provides a principle or just a way to get through how you navigate rehab. Once really serious red flags are ruled out, it's mostly about just reintroducing those tissues to load and challenge and stimulus and absorbing force and producing force and changing direction and all of the things that that area needs to do as a human, rather than it being something like, okay, well, you have this specific injury, so this specific exercise is right for you. I get it though. It's messy, right? We humans crave order and we want a protocol.
Mm.
I remember being in PT school and we actually all were so annoyed with our professors that they wouldn't give us protocols for anything.
Mm.
In retrospect, it was really awesome, but I think we just didn't understand it yet. Where we're like, what do you mean you don't have a protocol for an MCL sprain? What do you mean? And it's like, well, no, it's just their knee has to do knee things again. So can it bend? Can it straighten? Can the quads contract eccentrically and concentrically? Can it tolerate rotation and side to side movement? Can you jump? Can you land? And I don't think any of us were, you know, qualified yet to think that way because we just had a really hard time with not getting like, here is this for this movement. So it's messy, it's uncomfortable. We want a formula, we want a recipe, but I would argue the formula should be for most people. Number one, am I creating a physiological stimulus with what I'm doing with this person? That helps a lot to understand if the exercise selection is correct or not. And then number two, am I creating a psychological change for this person too in a positive way? Am I showing them instead of telling them that this movement is safe? Am I showing them instead of telling them or over educating them with pain neuroscience why this stuff is important? And I think if you answer two of those questions, yes, you're probably on the right track.
There's a few things here, so I'll preface this. Sometimes longtime listeners will note that I sometimes bring up a knee injury. Okay, I'm getting older, 47. Okay. Try not to identify with that because we know there's some neuroscience around like you identify
For
with getting
sure.
older and it changes how you move and what have you. But I'm going to make a recommendation. Guys, if you have stairs with carpet and you wear socks when you go up and down those stairs, and I have this affliction where since I was a kid, I go up and down stairs fast. Great. Until foot comes out from under me, the edge of the last step. I'm a
Mm,
big guy. I'm a heavy guy. So I go flying, feet are out from under me. One of my leg buckles back and I land on it with my leg buckle under me. And I knew something wasn't great. So
mhm.
anyway, and I'd previously tweaked this knee a little bit. So thankfully, Sam Spinelli was in town a little bit later on. I
Great.
mean, having access to Dr. Sam Spinelli
He's the
Natural,
best.
right?
Yeah, that's awesome.
And him, and I got to shout out my one of my physios, Brendan DeForge. He's local here at Edmonton. Brendan is a beauty. And they both checked out my knee, and they actually both kind of like thought that maybe there was something different. So again, this is going to tie into a next question. Sorry for the side questioning. For a little while, what I noticed, like, sure, I definitely heard it. Like, and so Sam believed that I had sprained my ACL and maybe a quarter post injury. So, but fairly quickly, I could tolerate certain things, and even for a long time. But here's a weird thing: a free body weight squat, I notice a lot of apprehension, like internalized fear around doing it. Whereas I can deficit reverse lunge, single leg with it, no big deal. A pretty deep single leg press is no big deal. Pendulum squat can be hit or miss sometimes, but there are a bunch of things that I have zero issue with training. But a body weight bilateral squat is a bit spooky. Does that make sense? More so than a loaded, more stable pendulum squat. And so there is some fear around that, and I play with it. I'm getting better. Recently, I've been doing some reverse Nordics, and those have been feeling really good. But you know, if I go to do this body weight bilateral squat, I have apprehension now. It's getting a lot better. So I don't know if you have any insight into that, but it's definitely like, so I know there's some psychology in this stuff, but my experience of what my knee can do is different with different exercise selection.
Oh, it's so interesting. And I think that just also purely shows you too how variable the human experience is with injury. Like you explain that injury and there's immediately, I have preconceived notions in my head of what I would assume would be bothersome for you. And then you blow my mind and it's not. So it's stuff like that that I also think just kind of hedges back on that point of if I'm too obsessed with what I think your mechanism of injury and or tissue that would be injured is, again, once red flags are ruled out, then I'm probably going to keep doing things that are aligned with what I'm assuming in my head I should be doing instead of actually seeing what your in real time abilities, limitations, or apprehensions are. So that's like one part of it. I don't have a perfect answer for you, man. That's pretty interesting. I would say maybe, I mean, in general, sometimes purely bilateral movements are a little bit more uncomfortable after injury, whereas single leg movements, you can get in and out of positions a little bit different side to side. Body weight or being just free versus having the support of a machine like a hack squat can also be a common thing that we see where that's why machines are awesome, especially if you're fearful, because it's an excellent way to load the tissue that we care about in a really comfortable and what feels very safe for people too. So I would say maybe those are part of it, like single leg stuff. You can kind of just get into the position that feels best for each side. And then you have that support of the hack squat feeling more comfortable. I think maybe also like anytime somebody has knee pain, the test that we do is a body weight squat. So we kind of already internalize that thought of like, okay, is this going to be okay? And I think we're wrapped up in that, of that almost being like our metric for, well, okay, if this doesn't feel good, then something is wrong. So potentially some internalized thoughts around that. I don't know, but that is very interesting for sure.
I mean, I know there's interplay, as is with all injuries, between my psychological experience of the injury and the nature of the physical, damage to the knee and how it's repaired, right? So, I mean, I don't think, I certainly wasn't looking for your clinical diagnosis, more like an illustration of just how messy the stuff gets. So let's circle back a little bit to this last theme. And, you talked a lot about how, or I'll frame it this way. I think a lot of people come in to physical therapists, rehab doctors, and they expect a clear diagnosis. This tissue is damaged in this specific way, a diagnosis of that, and then a very clear treatment plan. All too often they think, well, the passive stuff that now we can go into the hard training stuff and how you believe that rehab should, I think someone shouldn't be able to walk into a facility and they shouldn't be able to tell whether or not you're doing rehab or they're training. So do you want to tackle that big ball of shit that I just threw at you?
The 17 points that you just put together in one.
I'm terrible once in a while for that. Sorry.
That's fine. I'll try to keep my thoughts organized in a bullet pointed list in my brain. I think first and foremost, I want to be clear that I'm not knocking people who like passive stuff or do it. For me, the way I kind of think about it, because I'm so physiology and psychology obsessed, where that really drives my decision making, like I mentioned before. If I want to give somebody the most psychological and physiologically biggest bang for their buck experience with me in the hour that I have with them, that's going to really, be very important for what I select to do with them that day. Based on what we know about what actually happens with passive care, it being very temporary, it being more related to a very general nervous system inhibition, versus any really specific tissue effects. And it honestly creating reliance for people thinking that they need it. That's enough information for me to not be interested. If I'm bringing things back to what my goals are, of how can I impact physiology and psychology the most? So that's really where my decision making comes in. There's nothing wrong with people who like things because it feels good, or people who maybe utilize these strategies to calm some stuff down and maybe start training or start moving. For me personally, I don't like it. It's not fun to me, and it's not driving the effect that I want. What's fun to me is nerding out over their program and figuring out how I can get them moving. And I also, again, just my bias is always going to be that. So just want to be clear on that too. I don't want to knock people unnecessarily, but and then so that's really like why I say that rehab and training should look the same. It's just a little bit of what their entry point might be. Um, so that's where that first initial session of seeing somebody, I would be so hesitant to start right away with manual therapy because it then can really set the tone of what they think they need and what they think they're getting. So I'm trying to get people moving as soon as I possibly can day one. So that's a big part of that too. I just got very excited about that question. So can you remind me of the other points that you asked, please?
Well, it started out with any thought to the person who comes in expecting a very clear diagnosis and a very clear, hey, this is the prescription that will heal it.
Perfect. Yeah. So that's where managing expectations from the beginning comes into play too. I want to make sure that when I'm working with somebody, that by me not being hyper specific on a diagnosis, that they don't get the message that I'm not taking it seriously or that I don't have a clear plan for them. So I think the biggest thing is being extremely clear and repeating it if you need to, that my job is to rule out things that are dangerous. My job is to rule out things that are red flag that would warrant me sending you somewhere else, or that would really change and provide contraindications for what I'm safely able to do with you. I do that day one. I do that every single day. I'm constantly reassessing that. Once I've ruled that out, we're able to really operate more on an individualized basis for you about what are the things that currently bother you? What's the position that's hardest for you right now? What do you want to get back to? What are your goal activities? What's your current limitation? What are your current rock star qualities that you can do really well? And creating a really clear plan based on that. So that's a big part of it, just setting that expectation day one. And then also from there, if there are things that would be important for this person to know, if somebody's dealing with a chronic tendinopathy, it would be irresponsible of me to not tell them this is going to take a long time, or to not tell them some components of their rehab process instead of just like, yeah, we got to get your knee being a better knee again. Like there are some more specifics that I would need to go into. But again, at the end of the day, I probably just need to make their whole body and that knee joint in particular tolerate what they're asking it to do a little bit better. Maybe we have to calm it down a little bit first with some ISOs or things that might even be what people would consider more tendon specific, but ultimately the goal comes back to the big picture. So that's a big part of it. I think being able to be clear with that from the beginning is important. And then absolutely being clear with the plan. I think most people who come to rehab, their frustrations are that they often leave feeling that they don't know what the plan is, or if there even is one. And so that's something that we also, I think, all need to be really clear about with people. We don't have to have all the answers. I might not know exactly what every single session might look like after I've met somebody for one time, but being very clear of the general themes of the findings of today. So the limitations that we found, the areas that you rock at and are already really solid that we're going to keep prioritizing. And then how do we kind of blend that with the things that we found were opportunities for us today? And here are some milestones that I'm going to want to hit along the way. And I'm clear that I say milestones instead of timelines too, because for tissues, we have more milestones and things that I want people to be able to achieve rather than saying, well, at 6 weeks, you should be able to run again. I don't know if that's going to happen. I need to see if all of the things that we have to put together for you to be able to run again are happening before we get there. So ruling out red flags, being clear when things do matter about somebody's diagnosis, and then also being really clear with the plan, regardless of diagnosis, is extremely important.
And can you speak more on your way of describing it as rehab should look? Someone shouldn't be able to tell if someone is rehabbing or strength training?
Yeah, I think I've said this a few times before, but I think one of the biggest misfortunes of rehab is kind of this simultaneous overcomplication of exercise, but then underdosing of exercise at the same time.
Mm,
And people think that there's a difference between a rehab exercise and a training exercise, and that a rehab exercise is in quotations, a corrective or a
mm.
drill or a thing, some certain very low level thing that you're not allowed to do or that you're not allowed to progress from until you're healed and you're cured and you're fixed, versus training looking very different. And I don't subscribe to that. Physiology doesn't either, and surprise, neither does psychology. If I only give people really low level, in quotations again, correctives all of the time, I am sure as shit not getting their tissues ready for anything that they actually want to get back to doing. The joke is always like, you're going to give a power lifter who deadlifts 700 pounds a clamshell and expect that to be the thing that gets them ready to deadlift again. That's hilarious. And then also on top of that, it creates this idea that exercise is unsafe and I'm only allowed to do these banded exercises,
Mm.
or I'm so fragile and broken that this is only the only thing that my body can currently tolerate. And I think both of those things of your tissues not being challenged and nor your brain are devastating, especially early in the rehab process, to set the tone for people. So ideally, if you walked into a facility, and I'm going to shout out Old Bull, what we do, where we are doing that hybrid rehab and training, our goal is exactly that. If you walked in, you wouldn't really know, because we're training the same patterns, we're training the same styles, we're emphasizing certain contraction styles where we care about slow, steady strength, we care about speed, we care about coordination, we care about um, being able to jump and run and all of those things, but the dosage is going to be different. Maybe the range of motion is different, or the specific modification that we're using might be different. But if I want to get stronger and I have to just keep squatting more each time I train, don't you think it works the same way if I want to squat again after an injury? It blows my mind that people don't think that way, but it couldn't be more clear in my opinion.
You remind me, I'll reference Sam Spinelli again. It was a presentation he did a couple of years ago, and it just stuck with me about this sweet spot. And it was sort of this bell curve where, if you want to talk about this and go in depth and explain it, where too little stimulus is, I don't want to say degenerative, but I guess it kind of is. And then too much stimulus, well, that could be injurious. So do you want to do a better job with that?
Yeah, that's a really good. I like that a lot. I think that comes back to the conversation of dosage, right? Too, of that being more of the modifiable factor that matters a lot with people like surfing the curve of rehab and training. That dosage of, yeah, too little of a stimulus, we're not doing anything and we're wasting our time. And if you want to go as far as saying kind of degeneration, yeah, you're under preparing your tissues over and over and over again, and then they can't do what you're asking them to do in the real world. And if you want to take that a step further too, from the metabolic health implications, if you're just like under training and detraining all of your tissues, you're also not getting any of the big picture effects that I think are really important. Better body composition, better utilization of glucose when you are so to be able to actually be like a metabolically fitter person. Like that stuff is important. I can impact if I rehab somebody appropriately, and I can make those changes for people. Especially for those of us working with Gen Pop, most of these people have some other things under the hood in terms of comorbidities of health conditions that we care about beyond just zooming into their knee. So that's a huge part of it. And then on the other end of that is, yeah, kind of the overdoing it side of things, where it's not that we overuse our tissues. It's more that we're asking them and pushing them too hard beyond what they're currently able to tolerate as well. So that it is that sweet spot. And it's not perfect, right? Like this is where the conversation of being comfortable with flaring your own client up comes in, because we can think somebody's ready for that harder stimulus or that higher dosage, and maybe they weren't. And that's a whole other can of worms. How do you now make somebody feel safe who you've just pushed harder than maybe they were ready for? And that's where that trust and that conversation of, sometimes flares are a data point, and sometimes flares give us really good information, and that's a whole part of the journey too. But yeah, I mean that underdosing and then just making exercises so like weird and overly complicated, yet you're not actually doing anything when you really think about your stimulus side of it. I think that's the biggest problem with exercise selection in rehab.
Let's take this even further on the role of strengthening tissue and, managing pain, reducing pain. Is there a relationship there?
That's always the tough part, right? We don't have super clear evidence that just if you're stronger, you're going to be pain free, right? Think of all of us who are in the industry who are very strong, and none of us are pain free. So I think if you can, there's not a ton of evidence that just strength itself or training itself is a preventative factor from being completely pain free. I think of it more as, well, we have really robust evidence of all of the downstream effects of us being healthier and having better health outcomes down the line, and having less likelihood of diseases that are pretty terrible for our cardiovascular system and our metabolic system and organ systems in general. Um, I also think of it as from more of like a capacity and a tolerance standpoint. If your muscles are stronger and can tolerate more and have the capacity to handle the things that you're asking them to do, I think we can all say that there's going to be less stress on other parts of the body. Think of our muscles as a pillow to absorb the force of what our joints do. And if we don't have that pillow or that cushion, it's going to go other places. So I think that's a fair thing to discuss too. I also think from a pain or an injury standpoint, again, getting back into the psychology side of it, I think just strength training and like knowing how to do hard stuff and push through something that's difficult is an invaluable skill beyond just the physical benefits of strength training. Yes, I love getting bigger muscles and I like being stronger and I like progressing, but I would also argue something that's so valuable for loving strength training is like, I think I can handle some hard stuff. I know what it feels like to push hard. And if you can push yourself hard physically and get out of your own negative self-talk of like, man, I don't think I'm going to be able to do this, the benefits that has into every other aspect of our lives is just huge, in my opinion.
How do you bring the reluctant person to the table to be collaborative with everything you just talked about?
Great question. Yeah, this is stuff I'm constantly trying to get better at. I think because I think a lot of people in the industry can relate to this. We are so passionate about this stuff, and we have to remember that like we have the luxury of kind of being the weirdos who like to train. Most people don't love it the way that we do, so much that we created an entire profession around it and talk about it on a podcast on a Saturday. So that I think is really important to remember when you're working with people, and that there might be some compromises or there might be some, it might be harder to get people to those points. But I think showing our own enthusiasm about it is actually really important too, because we're walking the walk. We care about it too. You brought up a good point earlier about kind of not wanting to identify and self-identify with the thought of getting older because of the societal implications and the psychological implications of that. I think it's important for us as people who are going through our own aging processes in the fitness industry to talk about them and to also help people reframe their own concerns about aging as more of like a, well, let's see what we can do. Let's see how much we can violate people's expectations of what we think aging is. So I think those things are helpful for people who maybe are more reluctant or who aren't as excited about it, as being real with them about our own struggles, being real but with them about the things that have changed for us in our training too. And how we approach pain and how we approach aging are the things that maybe that are bogging them down mentally as well. But that's hard. It's not perfect. Like I mentioned, we're the weirdos who love this stuff, and we have to be sensitive that not everybody is going to be as excited about training as we are. But hopefully the environment that you're creating is going to be one that is at least fun for them, that they can maybe, I actually have a client who tells me this all the time. She's like, no, I don't like this. I like coming to train with you. And she's like, I don't want to be here at all, but it's fun with you. And I think that's important too. We might never make somebody like super obsessed with it like we are, but we can have that reaction.
Oh, it's a cheat code. So here's a little hint. I'm working on a very big project that I think will be, I don't want to get into too much detail, but I've been polling a lot of my clients about what they like about the experience of training, what have you. And one of the consistent themes is their relationship. So I'll reveal more details in the not too distant future about what I've got, but I've got something big.
Okay, oh, that's exciting.
One last piece that ties in really well with this is you like reframing the phrase overuse injury into more of someone is unprepared, the tissue is unprepared for that. And that
hmm
aligns really nicely with something that muscle doc Jordan Shallow says, and
hmm
I parrot it tons, is injury is, well, let's say the word caused by force exceeds tissue tolerance. So anything there that you want to elaborate on?
I like that term too, force exceeding tissue tolerance. I think first and foremost, the reframe is really important because it shifts this idea of I'm broken and there's nothing I can do about it because I've worn my body down too much versus, oh, the thing that I asked my body to do was pretty tough. And I hadn't really done something like that or done training in a way to get my body ready for it. It's this shift from there's nothing I can do about it and my body sucks. And I'm just adding this negative thought process of my body is withering away every day versus this is actionable. This is stuff that I can absolutely make changes and it's in my control. If you know anything about being in pain, which we all have been, one of the worst parts of it is feeling like you're out of control in your own body. So if you start to give people a little bit of control back, like this is something to work toward, I think that's a huge part of it too. And then additionally beyond that, like I think a huge issue that I take with just the term overuse in general, and I've talked about this a lot, less than 20% of Americans meet physical activity guidelines. I don't think people are overusing things. I think that's an incredibly irresponsible thing to say to a population that is majority of it is extremely sedentary. So if we create this idea that somebody who is sitting down all day and then they go and walk, that they've overused something, now I'm just creating another barrier to exercise for this person who needs it the most. That's an extreme case, right? Not every single person we see is that sedentary, but I think the messaging is that important because everybody knows the term overuse. Most physicians say these things. And that's very, very damaging to somebody who already isn't like hitting those kind of the low hanging fruit for just being healthier and more active. And then if we think of more of probably a lot of our population, just general population, the people who are a little bit higher activity level, it's the same idea of just like, well, I don't want to do something too hard because I'm just going to break down. It's like, no, we have a lot of work that can be done to make your body and your tissues really able to tolerate things. And it comes back to the progressive overload side of things. That's how we get people out of kind of they're feeling stuck with injuries because it's that cycle of, well, I did the 50 band exercises that you told me to do on the floor, and then I tried squatting again and it still hurt. So I guess I must be broken. Instead of creating that progressive overload situation where we can gradually introduce tougher and tougher positions for this person to be able to tolerate squatting again, I'm preparing their tissues. I'm actually making them able to tolerate the force that we're asking them to. They have the capacity to do so.
I can understand why your clients get great results. And I hope everybody listening, who most people probably deal with some sort of injury, this is really positive, refreshing, and helpful because immersing myself in these discussions helps me manage. I had identity for a very long time as being absolutely indestructible. Now, and yeah, I came out of the meathead world, so I probably pushed a lot of stuff, but I don't think I was particularly reckless. But yes, then a few years ago, stuff started hurting and not getting better back to baseline where I full range of motion and no pain. And I also sort of accept that it's always be like this, which I think is a tricky thing. Well, I'm able to work around it, but hearing these things makes me feel better. So I hope it's helpful for everybody else. Dr. Katie Dabrowski, everybody, they can find you Instagram, the letter K, the letter T, Dabrowski, anywhere else you
Yes.
want to send them.
Old Bull Athletics is our gym Instagram as well. We have just the most incredible team. And if you want to learn from some badasses in the industry, that's exactly where to go. Couldn't be more proud to be a part of something so incredible. So I highly recommend checking out our gym page and getting to know some of the team members. It's just a wealth of knowledge and I'm lucky to learn from them every day. And it's cool that you can too online. So head there. That would be my recommendation.
If you guys really enjoyed this episode, I've referenced Sam Spinelli. He's a good friend of mine. He's been on semi-recently and in the past. I've actually had a number of episodes on injury, pain, strength training, all that intersection with people like Dr. Susie Spurlock, who's incredible, Dr. Caleb
She's the
Burgess,
best.
Adam Meekins, Charlie Weingroff, Dr. Brandon Parker. Obviously, I went back recently and it's like, oh my God, there's been a lot of episodes that all overlapped and intersect. And I actually still think this may be the best one yet, just based on the lessons and how positive I feel about everything coming out of this. So everybody go follow Katie, please. And they could also go listen to a great episode you did on Coach 'em Up podcast. So, and it's a great resource. I've had both Zach Zillner and Tim Riley on recently as well. If you like those, check that out. But basically, if you're someone just finding the podcast here, I would love to have you stick around. I've got a lot of great guests and more coming. So thank you so much, Katie. I appreciate you.
Thanks, Andrew. This was great.